want to come to work, start at 8 o'clock and close at 2. Because of that, those who want to do their work and come later for the services will not be able to come. But if mothers know that 24 hours services are there, and they can come at any time that they want to access services, they will plan their time and at their convenience come and access the services. So it will help improve coverage, family planning services, maternal health services, immunization services, all our indicators will improve. But mothers will come at their convenience, committee members will come at their convenience, and it will improve health and babies.
Thank you so much. Our Metro Public Health Nurse, I know that talking about 24-hour service provision is our, and as Madam just said, vaccination, public health services. Do we really do 24-hour services? Since you are the head of the public health, how do you bring in your area into this discussion, 24-hour service?
Thank you very much, Director. So the reason we are all directing our energies to the 24-hour service provision is because there have been this traditional time that we've restricted ourselves to. And when we take immunization, for example, we know that it has always been limited to the traditional timing. And it is of no wonder why we have dropout rate increasing. So I think it's timely that the 24-hour service even affects immunization areas. So until now, it hasn't been the case. But effective today, with the embracing of this 24-hour service provision, we hope to incorporate giving immunizations into it. Thank you.
Thank you very much. I am asking this because recently in my facility, I tried something. There was going to be holidays, this double holiday thing, and I went to the public health unit, which is also my unit, and sat them down and said, now we want more, so there's going to be 2 days within the week that babies and mothers cannot. And answer I got is that I should go and check the whole Ghana. No public health nurse goes to work on a holiday. that was the response. I forced my way the first time. The next time, a whole delegation came to my office to come and renegotiate. So I think that discussion should start. Yes, we can, no problem. But at least public holidays that come with it, like the way the other nurses, other units of staff are also providing service. We should take it from there so that we will have more of a continued service provision. So I want to go to my brother, Doc. So what are the main challenges that you have experienced in your vast number of years in practice as a clinician in the implementation of this? We are already doing the 24-hour service, so now I can confidently say that you have experience in that. There are some challenges I've said in your practice when it comes to implementing this 24-hour service, especially in the sub-districts.
Right. Thank you for your question. The 24 hours service delivery, like your boss said, if done well, is going to yield a lot of positive results. However, Ghana Health Service, since the health sector reforms, has the clinics, the hospitals were mandated to do 24-hour services. And for the district and then the regional, we somehow were able to meet that mandate to an extent. But the sub-districts, the health centers, the chief compounds, that's where we have the biggest of problems. And why do we have these problems? A number of issues may come up. And then top amongst them is the human resource. Do we have the people to run the 24-hour service? How many midwives, how many PAs are at the health centers, are at the polyclinics, are at the CHIP compounds? How many, and you see, health service is not only about PE, about midwives. You need the bio medical scientists, you need somebody, the record person, you need the health and information officer. I think somewhere along the line we decided to introduce the model systems where everybody, we decided to staff these model health centers with all the caliber of staff you need to get the result that we're looking for. And so those models they had the PAs, they had the midwives, they had the, but in the conventional one, we have only one midwife, and then that was all we could talk about. Then comes the infrastructure. You take a typical health center, and then if we are fortunate, then we will have one accommodation, one room for somebody to live there. That means that that person is going to live there 24/7. And we are humans. How can we do it every night for 7 days, for 30 or 31 days, depending on. So the infrastructure does not allow us to employ more. If you employ more, then you will have to find a facility outside or an accommodation outside where the facility is. And when you find an accommodation outside the facility, then you think that you have to cater for the safety of the person. There comes in the security issues. How many of our health centers can boldly employ people on, those Ghana Health Service would employ security, would employ orderlies, would employ all cadre of staff. But as they exited, then it is incumbent on the facility to use IGF to do this. And again, the IGF capacity of these health centers may not be able to support the employing or the engagement of some of these cadre. So there's a huge gap there. And a few instances, we've had people working at health centers, child compounds, who have been attacked by robberies. Sometimes they are attacked even by community members. Okay, so who takes care? I am always the first person to go to the defense of my staff, i.e., the safety of them. I would always defend them. I would never subject a staff to a place where I think his or her safety is not guaranteed or is not assured. And so when you consider these safety issues, then sometimes it becomes important. I live here in the middle of the night, I have to go and then steal somebody. Yes, my own safety is not being guaranteed. Then why don't I still put and then steal it tomorrow morning when I know that I am safe enough? So it's some of the issues. Again, we talk about consumables. How do we supply constant consumable availability at these places? At one point it is there, at another point it's not there. At the health centers, like we do know, the district health will go and take from RMS and then do the supply to these sub-districts. And sometimes there are huge supply gaps because communities may be out of stock and then go. And again, they do not have the financial capacity to shop from the open market. So if the item is not there, then of course they cannot supply. So I think these are some of the few challenges.
In fact, you have given us a very extensive insight into this topic. So we now know the challenges, but as you know, we have a aim. We want to get something. How do we get it? So I now want to bring in our Mr. Director. Since this office, he visits this on a daily basis. So sir, how do we go around some of these problems that Dr. brought up?
All right, thank you, Mr. Chairman, the Union Director, and all other protocol duly observed. The challenge of healthcare services, especially regarding our implementation of the 24-hour services, as listed by our colleague, I know we cannot address all, but some of the things or the ways we can try to address them may include, in part of our limited resources in case like human resource, we could look at tax safety. But it's not all as you said, facilities don't have the staff. So we look at tax routine, when they're trained and given the necessary capacity building to be able to hold the fort in absence of the others, I think it will help to reduce the workload. We can also look at other innovations like telemedicine. Telemedicine can come into place where the sub-district level facilities, the 2 zones or the health center in particular, you could have our experienced medical officers in the district of polyclinics offer on-phone services or Zoom, even having the WhatsApp. So any way we can use that telemedicine process for them to get the knowledge, transfer of knowledge and skills, I think it can help them. Then also, we need to also let the public know about the challenges and also educate them about the 24-hour services that we are already running and which want to roll out fully. So if they get to know and they are aware that staff are there or they are not there, and these are the interventions we put in place, I think it can also help to do that. They are also addressing the security concerns as you indicated. If we're able to address the security concerns, where government could recruit security officers, allow a health center or recruit health centers, security officer for the health centers, so that at any point in time, when somebody comes, whether day or night, at least they can get a staff called with the necessary security guarantees to go attend and provide the services. I think if you do some of this, also it will help. And also, we're also doing the wellness clinic. The wellness clinic is a policy that if we do it well, it can actually reduce the workload of our OPDs. Because if we're there, people will know how to go and join the queues. They will go to the wellness clinic and they're attended to by the staff who are there. And when we do that, it's going to reduce the workload at the OPDs. And we're going to have an efficient 24-hour services running in our 2 zones or the health centers.
Thank you very much. It's very practical. So still on trying to address these issues, you were talking about the wellness clinic. So it's all about access. And then when we talk about access, it's not just about the geographical one, we're also talking about the financial and all that. How are the facilities going to sustain these wellness clinics in terms of consumables? Doc mentioned consumables throughout the year and all that. How are we going to do that?
So as it is now, when they go, what we are currently doing now, actually they don't have to pay for anything. They just walk in, walk in and they have their...
So who pays for it? Well, there's nothing free. If you get something free, somebody is paying for it.
Yeah, so the system that kind of takes care of it. So the person will not pay out of pocket. So but the system taking it, the health system, so and the health facility levels, the insurance will come in here. Okay. Because when they go and they check all those kind of the BP monitor and all that, yes, the system will take care of it. But the person will not pay out of pocket.
But Director, I don't know, Doc is here, she will throw more light on it. But the insurance people usually will want diagnosis and all that. Would they take coming for wellness clinic, just checking your BP and pay for
so
it?
So that's why if it's well done, it's part of the policy that we want to encourage people to visit the wellness clinics. So there's a policy intervention to allow them to go in and be paid, and so the services that they get, they can be paid for. And that will encourage people to go to a wellness clinic services. And as I said earlier on, that's going to reduce the load at the OPDs or the main services center.
Thank you very much. Let me come back to my professor, Madam Samson. So, Madam, now we are talking about how to make this 24-hour. In your experience as a clinician, you have been a nurse for a long time and all that. How can nursing and midwifery services be enhanced in the context of this 24-hour service that we are talking about? What are some things some innovations that can come in Now we are talking about finding solutions. That's for the problems, we have mentioned them. I want to see if you will be well prepared to be able to follow through with this concept, new thing that is coming to. Even though we are already doing it, but how would we do it better?
We will do it, thank you, we'll do it better. Nursing and midwifery, we need more staff. Doctor mentioned shortage of, if you have one midwife in a chief zone or in the community working as a primary caregiver, she can't do 24 hours alone. So we need more nurses and midwives to be posted to the primary healthcare level to work so that we can run the 3 shifts. Some will go in the morning, some will go in the afternoon, and during the night. Then they have to be given regular refresher trainings, because if we don't train them regularly, they will lose their skills. So we need to give them regular training. Then we also have to bring in more innovative ideas, like the use of digital means, yes, telemedicine. Then digital health records, so that, for example, limbs can be used at the primary healthcare level, so that if I have the digital records there, I can easily access patient information. So we have to bring in digital records. Then also, we have to involve community members. The nurse cannot work alone, so that the nurse will have to work with community members, so that community members can support the nurse. Where we have shortages, the community involvement can be a way of assisting the nurse.
Which particular areas will you want the community to come in here to assist? If we are meeting them today, we want to tell them, so we are thinking of your support. Where will we ask them to focus on for us?
There is a community volunteers.
Okay.
Because the nurse can work with volunteers. The volunteers will be the liaison officers between the community and the facility.
We can also, like Metro, the municipal health director was saying, security, for instance, maybe we can get a community to come together to protect these cheap compounds. Usually the problems are at the sub-district. That's why our discussion is focusing more on the sub. For the district hospital level, usually we don't have much problem, but the sub-districts, that's usually where
the issue is at the community level.
Yes.
The community level where we have the chiefs.
Yes.
Where the security there is also an issue.
Yes, it's very bad.
So the community can also support in that area. We can identify community members who can be at the facility level as security men to support in that area.
Okay. Thank you very much. I want Metro Public Health Nurse to throw more light on the role of the public health nurse. The role of the public health nurse when it comes to making this 24-hour thing work well, so that we can reduce the cases, especially the emergency cases that are coming to us. What can the public health nurse do to support in this regard?
Thank you very much. The public health nurse is key if we are considering the 24-hour service. And as a manager and a liaison to other stakeholders, she has a role to play. We all know that primary health care is about providing basic but essential services to individuals in the community as a whole. And we encourage stakeholder participation. We engage stakeholders in the community if we want results. So the public health nurse is that link between the directorate and the community. And so, first of all, she has to create the awareness, let people know that it's high time we have considered the need to improve access, and it's high time we all put together to make sure that we execute it successfully. So we need their cooperation. I was happy when the keynote speaker, no, rather the rep for the regional minister, talked about a lot of resources, of financial resources being pumped into infrastructure, and then resources allocation. And he also talked about outreach, resources, and then continuous financial support. Yeah, so you may have a good dream, but for what we are talking about, stakeholder engagement is very key, and then continuous financing is also key, as well as, like I talked about, improving upon let's improve upon the quality assurance. So as a public health nurse, I will work in collaboration with my district director and my nurses for us to see how we can work it out so that everybody can be involved and there wouldn't be gaps. For example, we're talking about the traditional time we've all been used to working is up to 5 o'clock, and now we are going to say that we work 24 hours around the clock. A community health nurse or a public health nurse know that no, we haven't been working on weekends and holidays. But they are all stakeholders that we have to engage. And if we engage them right, we all understand, because our ultimate goal is to see that our people are having the best of services and increased access.
Thank you very much, and I'm happy you are saying you help us to engage them. So I'm sure you help us to engage them. I'll be inviting you one of these days so that we start engaging them, at least, not even during the weekend, but at least they can be dividing themselves, and then holiday, this part will come. That was the proposal I made, but I was told that I should wear hats everywhere. Nobody does that. Nobody does that in Ghana. So I think it's a good thing. When we do that, it will reduce some of. I also know that maybe perhaps because of challenges, now the public health nurses going into the community to do what the community health, that training was supposed to be doing, going down there, visiting the people. How far is that? How is that going to help in this?
Yeah, okay, let me clarify here that now public health nursing has merged to become one, where we have community health nurses, registered community health nurses, and public health nurses coming as one. Together we are called preventive health nurses of Ghana. Yeah, so your question was?
Going to the communities.
Yeah, of late we realized that home visits seem to be on the low. And this has affected the decentralized care that we all look forward to, because we know that primary health care is all about taking the services to the doorsteps of the people. And there are reasons why some people cannot come to the facility. So of late, personally, in our metropolis, we have had our nurses coming together and reawakening that desire for home visits. Okay, we have even brought back the system of bringing in the bags. We had a special bag, which was like a one-stop shop for providing services. I just don't understand. First, we're so passionate about going around with our bags to homes, and we had everything there that will provide that basic but essential services. But these days, perhaps because things seem to have changed, where the initial concept of the chips have been a little diluted, where it's more like a clinic than a chips compound. So perhaps because of the need for resources, we have made it like a clinic. But I think we should consider going back to take the services to the people. Of course, because we cannot go in the night for outreach, it's necessary that we have a compound, okay, and then the infrastructure is well equipped to provide the services that we need to give our people.
Thank you very much. Let me go back to my brother, Dr. Bodu. Doc, so do you know of any models that had been used anywhere that had been found to be successful in trying to deliver this kind of service we are talking about? Like we now want to do 24-hour service. and also try to get stakeholders and everybody to come together. What are some models that we can start looking at? We have mentioned quite a few, but have you read or experienced any of this? How telemedicine, for instance, has been used successfully somewhere, some place? We want to share some experience with us.
Yes. Sometimes models will be influenced by the circumstances on the ground, the structure of the health or the health structure being practiced. And then so you go out there, internationally, and places like Korea and China have similar programs. Their health structures are community owned. And so there's, in terms of the hierarchy, in terms of the ownership, may be different slightly from what we do practice here. But of course, you go there and the equivalent of our health centers are massive structures. If I say massive, not in terms of how enormous the structure is, but then they are well equipped. So you go to the structure, equivalent of a health center, they have CT scans, they have 4D ultrasounds, they have almost everything, ECG. So you go to the health center, then it's like they can do everything for you.
Yeah, so it means maybe our teaching hospital, maybe a health center.
Please, I didn't say that. And then again, they also have the human resource too. Down there, you have the PSRE, the doctors, the midwives, the nurses are out there. Here, we may not have the benefits of those items and the systems I'm talking about. However, we also have what we can use to achieve, if not the same, similar outcomes. And so I'm glad that you mentioned the telemedicine. When I was in Ashanti region, I was fortunate to have the regional telemedicine in my hospital. And then those days, it was a very effective platform for transmitting and discussing cases. So, telemedicine has a very wide spectrum, from the basic, which may be testing, to the other end, which may be videoing. But what we were doing was something closer to the basic. And so we had the teleconsultation center where most of the sub-districts could call into. Okay, and then we also have people who were trained and then also in a way motivated doctors, where the TCC could reach out at any point in time, not only during the day but even at night. Okay, so cases before, and then the region has also been zoned. So at any point in time, when you call in, we know the closest facility to you. In the case, the midwives or the nurses will discuss the case with you, and when it's beyond you, they'll refer you to a doctor who will have a chat with you and say, no, at this point, I think that this case is beyond you. So the nearest center which can handle this case is, let's say, here. So please send that case there. And for a period, it was doing the job for us until, of course, very severe challenge, the server and everything broke down and it could not be repaired. So telemedicine is one effective way. These days, I was speaking with DD, and we wanted to read what we had at the regional hospital. But we also realized that WhatsApps are becoming, now people have personal, we have group WhatsApps. So ONG, they have their own WhatsApp, pedics, they have their own neonatology, those, they have their own. So the WhatsApp, in a way, for me, is a way of medicine consultations.
A good platform.
Exactly. And then they are discussing this. I think that we also have to let people know, especially the senior doctors, senior midwives, senior nurses, that look, yes, you may be practicing, but if you are to limit your practice to your center, then certainly all the bad cases will end up at your center. I remember between a membership and the fellowship, my boss called me, Kwame, what are you doing? So I'm doing some 1 year here, and then I'll go back. And I said, look, if you go, all the bad cases will end up to exactly. And once we have that, then you'll be willing to share whatever you are doing with the people out there. Okay, training, refresher training, like she said, and then a few other things. If you're able to do this, I think our outcomes will be better.
Thank you so much. Let me talk to the municipal director. Director, Doc has spoken a lot about this telemedicine, but his concentration and his have been more between worker, health, the workers. How do we let this also get straight to the population so that they can also be at home? We are talking about 24-hour service. So if at 1 a.m. it's not feeling well and you want somebody to consult, they want to use telemedicine. Is this possible?
Okay, thank you. I think it's possible, but one thing that we're also doing well is home-based care. Home-based care, I think we're all doing it, especially example is through the COVID-19 pandemic. I can remember very well how Dr. Kwa and the case management team were doing a lot of good things using the home-based care method. That reduced the pressure on the health system at the facilities. So home-based care can
So in
help.
this, what exactly do you mean? Are you saying that the workers should go and visit?
That's the kind of the home visit that they will go there, especially those with chronic conditions. Instead, they come into the facility almost every day. But I will start going there to take care of them. That is being done, as indicated, during COVID, then even with TB.
But is it possible in our current circumstances?
Then now that we want to run a 24-hour services, we will have to have deliberate intervention policy to make it come. Then I think to also add on about the models that have been implemented.
Yes, absolutely.
I want to add on. Come to Ghana, even though our just concept has challenges, but it's one of the globally acclaimed primary healthcare system that other countries have come to let me say, copy to go and adjust, they do a lot of things. If you go to Ethiopia, they understand they came to learn from us and they want to implement the community health worker system. And that is doing wonders there in terms of primary health care. So when it comes to these two policies that can enhance 24-hour services, the two compound, the two systems there. After all, we always indicate that we are running 24-hour services. The only challenge is the resources. But if the resources are provided in terms of human resource, the logistics and supplies, I think we can do it better. Okay. Then if you also go to other countries which have well-developed primary healthcare system, they're almost close to achieving the universal health coverage. Primary healthcare is a bedrock to achieving universal health coverage. So I think these models are there. Ghana is a case study. Ethiopia is a case study. If you go to Netherlands, so they have very efficient primary care system that is doing wonders.
Thank you. So I want to talk to Professor. So
the issue is the NOP.
Okay, the network.
Which is not the network practice.
Yes.
It's a current issue of Ghana service for the Ministry of Health.
Okay.
That if we do well, we are able to group credentialing, where you can come to Ghana and share resources, knowledge, staff, all that. So it is a policy intervention of the service for the ministry. That is what it's a good thing that can help us achieve the 24-hour services.
So you just landed on where I was going to. Going to talk about policies. So I wanted to know, Madam, what policies, if you want to see roles that policies can play in this, what policies do you think we should have to make sure this thing works, so that we can advise the politicians and the policymakers and all the others to be able to do this for us?
Thank you. Before I talk about the policy, I want to add a few models that will help improve primary health. Our polyclinic system we have in our teaching hospitals, because they run 24 hours. When you want to refer, you can refer from the primary level to a polyclinic. Before, if you have to see maybe a specialist, they see the specialist. So,
But do they do that?
yes, Polybu is having a polyclinic.
Yes, but our polyclinic here doesn't do that.
They don't do 24 hours.
No, they don't take direct referrals. if you are referring, it has to go
So
through the
there can be a
before
policy.
so that's the policy we are talking
There
about.
can be a policy that before maybe the primary level refers, the primary level can refer to the polyclinic first before maybe the consultants at the main facility will also see the patient. Then even in central region, we have the zonal system for maternal health. We can extend it to other services so that in the zone, the CHO at the primary level, if there is an issue, can even put it on the platform so that maybe especially to senior midwives, senior nurses, they can assist her or direct her on what to do. So our zonal system is also good. And when we extend it to other services, it will help improve primary health care.
Okay, so
Then the policy.
Yes, I'm coming. So that's on the zonal system. I'm very much interested because I know it's working well for the obstetrics. How can so it falls in line with what Doc said, the WhatsApp thing. So it means we need to deliberately see how we can get the other kids who are not midwives to also be on another platform.
Yes.
Still based on that zonal thing that we are doing. I think that should be an excellent one. So please proceed with the policies.
So the policies, we want to do 24-hour primary healthcare services. So we need to have policies to ensure that it works. Government should commit political will. We talked about political will this morning. So that what is the policy maker? What would the policy maker do if we have accepted to do it as a service? So there should be policies that's what we are doing. So every hand should be on deck. The government, the role of the government, provision of resources, provision of funding, then governance, leadership role. What should leaders do? Sometimes we have beautiful policies, but the execution becomes the problem. So that if we have the policies, we should ensure that we execute the policies. So the policy for the shift system, we talked about the shifts. How many shifts are we going to run if you are running 24 hours? You know, we already have 3 shift systems, nursing and midwifery practice, morning, afternoon, and night. Is it going to work? Because we don't have enough staff. Will 2 shifts help? That maybe some will come, are we going to do 12-hour shifts, or we are going to do 8-hour shifts? So these are all policies we should ensure that we put in place so that we know what we are doing. If it is monitoring and supervision, how often do we have to go to the primary level to monitor or supervise? Who should do it? Are we going to give them, and how are we going to ensure that they have adequate skills to do the work? Is it going to be mentorship? Is it going to be supervision? So all these policies should be in place so that we know the way to go.
Thank you so much. You have done justice to the question. So, in a nutshell, we are saying that the concept is a good one, 24-hour healthcare provision. However, there are some quite serious challenges that we have brought out. We have also been able to proffer some solutions, even in the midst of the challenges in resource limited settings like ours. We have brought them up. And then we are saying that this concept should be accompanied with very clear policies. Prof, that's what we are just saying, very clear policies. So you want 24-hour, there should be policies on recruitment of staff to match it. There should be policies on even things like what has come out, how we are going to run the shifts. How about the 12-hour, if they change the policy to bring, okay, when we get there, you know, we have done it before in our hospital, you know, I've heard, yes, so I know what I'm talking about. When the mothers wake up at 6 and they said they should do 6 to 6, and it was 6 to 6 and 6 to 6. It was easy, in fact. So they have to take up to all this and make sure that we don't have something hanging, but then there are good policies to back them. And then more importantly, like you said also, the funding. We need money. We need money. So, ladies and gentlemen, I think we have exhausted the topic that has been given to us. I want to thank you so much for sharing your insight. Doc, I don't know if you have some last words on this topic before we leave.
Yes, I just want to say or add that we should also engage other stakeholders, because we know the challenges, especially the security. So is it possible to get the Ghana Police Service from Interior Ministry to offer some form of support to the health centers, the chip compounds, and then home, or like I said, the community volunteers. And then on the HR, sometimes the assemblies are able to employ people on their IGF. So if they can get one or two security people on the assemblies IGF for the health centers, which cannot use the IGF to employ. So we should get these stakeholders to be part of the 24-hour service, not only help. We shouldn't carry everything on our tiny shoulders, but we should seek help from appropriate quarters.
Thank you very much. So what you have just
just also an addition. As you said, the policy provides the framework for which services are going to be done. Now, you want to have and efficient 24-hour health services. We need funding. What are the dedicated sources of funding to allow us to achieve this? The government has promised free primary health care. We those who are going to implement the services, are we aware how it's going to be done? Because it's not like a policy only. So we need to be able to have the policy guidelines as how this is going to be done. Now, the funding aspect of it, as I indicated, is very, very key. Because if you're going to provide primary health care free at a just compound, as we speak now, getting funds for those level of facilities is a problem. How are they going to fund it? What is the source? Now we're having, I can say the COVID-19 levy, which the government promised to eliminate. I've heard other people calling for this retention, to which, for me or to those people making the cost, is a low-hanging fruit. After 1%, it's just kind of woman that from what you buy. So if that could be converted into public health fund, it could save us dedicated source of funding for government to roll out these primary health care services. One day, renew the services. They will be fun for people to have access to that they can use to get the supplies, the logistics, and even recruit the security that we're talking about. I think that's the addition I want to add. Thank you.
Thank you very much.
I also want to add that we have to put in sustainability measures, because sometimes we bring out beautiful policies, beautiful plans, but we execute them to some level and we stop because we didn't plan well. And we didn't put in sustainability measures to ensure that it will be there throughout.
Thank you very much. And I know the politicians are trying to put in measures to make this thing sustainable. That's why it's got our dedicated funds.
I want to take this opportunity to appreciate our regional director and team for having me on this panel. Yeah, in conclusion, what I want to say is that if we are talking about going 24 hours, infrastructure is key, human resource is key, security is key, transportation and communication are key. And these days, we are moving from that top-down approach. We are now going down to the communities, or we should see the need to go down to the community to communicate this agenda. All stakeholders, especially from the top. Let's go down to the community and let them appreciate this need. It's going to help everybody. And I and my team, I know we are all ready to take this agenda far. Thank you.
Thank you. So let's all look out for the policies. I know the policies will come. When it comes to, let's open our eyes and read them. I was there recently when some people came on this NOPs, come and audit my facility, get to know how much money I've got. I said, money, nothing about money on it. I said, no, it's there, the policy is there. I have to come and see the regional director from my share because I'm not receiving it. So when the policies come, let's see what is in there. And on that note, on behalf of my panel, I want to say a big thank you to regional director and all those who put this together for the opportunity given us. We are very grateful.
Ladies and gentlemen, as we have come to the close of this engaging and insightful panel discussion, I would like to take a moment to thank each of you for your participation and thoughtful contributions. Today's discussion on the delivery of 24-hour primary health care services has brought to light both the challenges and the opportunities that we face in making health care more accessible, equitable, and responsive to the needs of our communities. As Mrs. Nyakusamti said, if we are able to implement the 24-hour service very well, it will improve all the health indicators. She also said that we have to be more innovative. We should human resources to run the fresh, more human resources. They need more nurses and midwives. They should organize fresher courses and more innovative, like the digital health records and telemedicine. We should involve the community members to volunteer to help the facilities. And she also said that because of the teaching hospital, they have polyclinics. It is easier for the polyclinics to do referrals to the hospitals. And she also said that we should encourage zonal system of health delivery. Mr. Martin Donko, the MDHS, also said that almost the same thing. He was asked, how do we go around the challenges? And he said we need more human resources. And we should do tax shifting. He also mentioned telemedicine. We should improve the security and wellness clinic and more consumables. And let me say that NHI does not pay for wellness clinic. We are hoping the new Mahama Care, if they include, but for now, NHI is not paying for wellness clinic. He also has also said that we should encourage telemedicine if it's possible. We should also encourage home care and also encourage NOPs. Madam Jones also said almost the same thing, that we should encourage the community leaders to help the facilities. We should create more awareness and have financial support and improve quality assurance units. And also awakening desire of the nurses and encourage them to do more home visits. Dr. Boydell also said that the regional hospitals are already doing 24 hours. But if we want to bring it down, then we will also need more human resources. Infrastructure has to be improved. The IGF is not sufficient. We will need more consumables. And he also talked about the models that we can learn from. He said Korea and China, they have a very good program and it's similar to what we want to do. So we should learn their models. We should learn how they go about it and learn. And he also talked about telemedicine among the telemedicine. And also encourage us to, their group, to also do more WhatsApp and inter-workers policies. And I think we have all come to conclusion that the 24-hour delivery will really help us. and that we should pray that it come, the Mahama Care, the policies and everything about it. The policy document should come so that we all know what to do. Thank you so much, and I think we'll just go to our second panel discussion. And I will not waste time, I'll just invite the moderator, Dr. John Yamba, Medical Director of UEW Hospital, with a big round of applause.
Thank you very much. Good afternoon. I think we have broken the protocol, so we won't lie on it or won't sit on it. So, with the indulgence of the chair, I would like to invite Reverend Atamensa, the DC for my district, Efutu. If he's here, he should join us on the high table. Reverend Atamensa, MC for Efutu. Okay. Then we would invite Mr. Fidelis Agna, DDHS, Upper Dentura West. Oh, please. I know you are not hungry, or are you hungry? So let's start from you. Dr. Edward Gatti. Dr. Gatti. Okay. Miss Linda Kwabia, RCC. And Nana Kwame Edu, the SIF, to Fuhene of the traditional area. Okay. So sitting down and listening to the fair discussion, we talk about 24-hour care. 24-hour care, and then looking at what we have to discuss, I think that we can just say good afternoon and go, because they have done our job for us. They have discussed about access to healthcare for us, but we'll still have to do our job. If not, the regional director would come after us. So we are looking at improving quality of primary health care and improving access to primary health care. All along the presentations in the morning, we're told that it's a business for all. And Prof particularly mentioned that the traditional rulers are the leads when it comes to the community. So I would like to find out from Nana what they would consider as quality when healthcare is being discussed, or what you would consider as an improvement in access to healthcare.
Thank you, Doc. Your question is loaded, because for everyone, when you say a traditional ruler, it's coming from the community. So he affects everyone. You see, quality does not really comes into being until and unless policy, financing, access, and infrastructure, provision of what we call the consumables, drugs, and knowledge come to bear on our health services. If the government, who should implement a policy, is adamant, or just go about launching this here, launching that there, without the necessary funding, then quality will not reach anybody. For us, it is incumbent for us to know that indeed these things are available, and that when everybody in the community is affected by one ailment or the other, he or she will be proud enough to go and access them. So it affects everybody, and we are all involved. Thank you.
Thank you very much. Nana says that the services should be available. Now the politicians go on launching programs. In terms of quality and access, Madam, what would you consider is of a high quality enough health services for you from the policy level?
Yeah, thank you very much, and good afternoon to you all. I would love to just start by saying the Regional Coordinating Council, we exist as the executive arm of the government to provide effective and efficient to oversee the activities of MMDAs, MDAs, and NGOs in the region. And let me start by commending the Regional Director for his poise to ensure that there is improvement in the primary health care. She came to, I was with them in the meeting that she came to the regional minister and came with the agenda. And everything was spelled out to really see how best we could collaborate. So I will talk about the collaboration. So, and involvement with RCC, because they are we are administrators, we are to see to the administration of the region. So when we come in, he will also, with the regional minister, will be of the political aspect. So together as a team, we'll be able to bring the quality to the citizens in the region. So let me put it this way that especially as she has started, we need to, most of the time, we, as I said, they're bringing those policies and we need to understand them. During the first session, you remember saying, what do you call it, the assemblies. With the common fund, they have a portion, the health. So during the assembly level, the health directors and the soaps, they need to have these collaborations to at that level to ensure. So that means they have those stakeholder meetings at the district assemblies, like the MMDs. So if they continue to pressure, let me put it this way, pressure, you know, the politicians they don't love.
You're a politician yourself, so we don't love to say the politician.
No, I work with them, but I am not a politician. Yes, I'm a technocrat. Yes, that's why I started by saying what IRCC exists to do. Yes, so if they have to push, especially with the stakeholder collaboration meetings, they need to be on their, if you continue persistently to be on their neck, that we need to have a meeting, because during those meetings that they are able to also know your issues. Okay, as they mentioned, the implementation, the policies are there, but the implementation is a problem. So when you keep on being on their neck, there will be this collaboration, there will be this meet up, then there will be a common goal, which they will understand. You need to, let me put again, the politicians need to understand what you have. When Madam came to the minister was so happy because she brought a spelled out agenda and what she wants to do, what the minister wrote to play in there. So if the assembly are also the MESOPs and the district health directors also go in with that on that aspect, the MMDCs are going to buy in that and will also help, especially with the financial aspect, so that whatever they are due, they will be given to them. Thank you.
All right, I think that unfortunately the pure politician is not here to take the hit. But I think you're a politician, so would you take the bullets for the politicians? My dear colleague, on this one you are on your own. Please, in terms of quality, do you feel or do you think that the services we are providing to the community, what should we do to meet the community's expectations in terms of quality and access?
Okay. Thank you very much for this opportunity. I think since we started the first session, we're talking about primary health care, and we've looked at it as a vehicle that will help to achieve universal health coverage. And as your question suggests, how do we get access? It's how we are going to get this quality in the area of access. It's more of like we have to collaborate with the community. Most of the times, realize that as a healthcare provider, we look at the community as merely beneficiaries of our services. But sometimes we have to look beyond that, that they are actually partners that have needs that need to be met. And sometimes somebody that has a need is the one that will be able to tell you exactly what need he or she has for you to meet. So if you're able to get to them and really understand what their needs are and see them as partners and not merely persons that we provide services for them to consume, but also get the feedback from them as to what exactly they need and whatever we are providing, whether it actually meets their expectation or not. I believe we'll be able to provide exactly what they need, and the access that we need to get to them, we'll be able to get that.
That's fine. I think that earlier on we all heard that primary health care is preventive, it's promotive, it's curative, and it's rehabilitative. From your point of view, or from your lenses, what strategies do you think that Nananom can use to influence these 4 levels so that we can be seen to be meeting the aspirations of the community?
Thank you very, very, very much. Dr. Gata has said some of these things, and I want to reiterate that when health services are presented as if it is for them, then you have a problem. If it is inclusive, the health service is there, but the community, the people in it, the citizenry, believe that it is us. That is why it is there. Then, whenever there is a program, the chiefs, the local people are involved. Today I was talking to, I met the regional director for the first time, so I was asking why is it that he has not come to us with some of these programs, so that whenever we meet at our hamlets, at our palaces, at our community level engagement, it must not necessarily be on health. But if there's a gathering, for example, the Effective Fashion Festival is international, and everybody somewhere will have to come back home. They will come back home before they participate. So if some of these engagements are involving, today there's something going on for the festival. If the chief knows about some of these things, then in their engagement with these people, with our people, then we're able to disseminate the information and the knowledge to them. Gone were the days, I don't know whether it is there now, where it has been mentioned, the home visits, the home-based care. Very, 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 very innovative. But then, I don't know whether it is still being practiced. It improves access because some of the not communicable diseases have very few attendants to attend to them. But if you come home and then you know that this enclave, there are about 3 people suffering from high blood pressure or whatever name they give them, then you give the person a dedicated nurse or public, whatever they call those in brown. They were visiting regularly. These things will help access. And that, because there's a catchment area for them. When you go to the chief or the local assembly man, that I'm coming here, I'm going there, I'm going here, it helps. Recently, students from the University of Lagos approached me. They wanted to demonstrate some of these, the things that they have learned.
when they came, I organized a place for them at the University of Cape Coast, where I stayed, Kwabo, and it became very, very, very engaging. And I went there and talked to them that they should not practice what we call over-the-counter health services. Get to the health personnel, get to the chief's compound, get to these people. Even if there's a nurse living in our community, make friends with them. These all help in access and quality care. Thank you very much.
Thank you very much. I think that would just translate into a question to Mr. Agna. As a Health Services Director, you've heard his concerns. How far do you go in bridging the seeming gap between the health services and then the community?
Thank you. I think that's what I said earlier. If we see the community and the leadership of the community as partners, I think we'll be able to get to them, to get their side.
I understand what you're going to say. I'm just going to, how far have you done that in Upper Denchira West?
Okay. So in Upper Denchira West, actually, we've done a lot in that direction. But we've collaborated, we've gone to the chiefs in most of our activities that we are doing, and I'm happy to announce here that due to those collaborations that we've had for our health center, the Directorate, that has been there, and if you come there, it's looking like a lorry park. Currently, through that collaboration, we are putting up a fence wall that is going to protect the land and also serve as security, so that at least the place, people cannot troop in at any time. And in some of our communities, we also have in some of our sub-districts where the community have actually put together a health fund, and they are putting up health infrastructure. They've put together a specialist ward, that's a private ward that contains a television, air condition, everything, and have 4 beds in that particular ward. Then we also have an emergency unit, though small, but it's able to serve the purpose for which it's been put together. They also saw the need to put together, a storeroom where we are going to put our medications for use. And they also actually looking at our terrain, because the nearest hospital, I would say, is Bibiani, which is outside our region, though. The nearest within our district is Dompao Government Hospital. So they also saw the need that due to the activities at that area, we have a lot of accident RTA cases. Some come in dead. So they've actually built a small place that will be like a holding bay for persons that unfortunately are brought in dead until they are conveyed to the morgue.
I thought you were going to tell us they built an ultra-modern emergency.
Yeah, so, and now the next project they are putting together, it's a multi-purpose building that will have a mini theater, a recovery area, and in the near future it's going to be a
I think we have to clap for Upper Denchira West. The evidence is that collaboration works, and so we those who are coming from, unfortunately my MC didn't come, but I'll go to his office when I go back, and I'll get my share of the common fund. But in terms of policy, these funds, we all hear they are disbursed. The politician always has somebody who is turning the person's neck. And I believe those are the technocrats around the politician. Given all these things you are hearing, what can you do to improve health? Yesterday I was looking at something and somebody said that health is the engine of, the president said health is the engine of productivity and not the economy being the engine of productivity. How do you help the politicians see what we see in terms of healthcare?
Thank you very much. You are trying to make me a politician here, but even though I am not, but since I'm working with them, let me also come in. As Nana and Doug said, it's all about education. There should be awareness creation and education that most of the time, whatever the health or the hospital is doing, the politicians are aware. They invite. Like I said earlier, you don't just write a letter to the politician and you sit back. You need to go to their doorsteps. Let me put it here, they always want to feel
They are not here, so
power. This power drunk, sort of, in quotes. So if you are able to always go to their doorstep, put in your challenges, and as we all said, and involve them from day one in meetings, your objectives, your goals for the half year, for the end of year. What is their aspect? What are they to do? Let me go a little out. When we are coming to have this panafest, some dignitaries came to visit them, pay a case call to the minister, and they spelled out what exactly the RCC are supposed to do. Immediately, the minister tasked me to form a small committee to work on it, to ensure. And he gave me that end of the day that I should send the committee members to him, and we meet that afternoon to see what RCCs do. And we were really poised to see to the ground. They spelled out what RCC are supposed to do. And all these things we were able to put in place because they came to him and they spelled out. So it's about not just writing a letter and sitting somewhere. Go to them, spell out what you want them to do for you. Okay, monetary, even, and also, let me put it in this way, that when you are having even this capacity training, most of the time you need to involve the assembly. Whoever should be let me see, the region, the one, like myself, desk officer, I need to also be abreast with whatever the health issues are. Then, what they spell out what RCC should do, what the assembly should do, we go and give a report out there. Then we can be on their neck to really come help us in that aspect. So I don't know if I've
I think the district directors, you have seen the formula for getting help. She has just spelled it out nicely. The formula is you write and you go and engage. I'm sure I've seen the regional director's itinerary. No, they'll come and visit you. So just be patient. In terms of challenges, what are some of the challenges you've had engaging stakeholders? Not just the stakeholders on the table, but the stakeholders beyond the gathering here.
Okay, thank you. I think as a district, if I should use my district as an example, the challenges are enormous. The stakeholders, the challenges that we face with engaging the stakeholders, most of the time when, especially the assembly, then the other departments that you think you can collaborate with them to be able to get your needs met, they kind of see you as a competition sort of, because we are all competing for that little resource. Because the assembly, we are happy here that there's a fund that the what do you call it? The health sector allocation will be made to the Directorate. I think when we go back, we are just praying that it's going to be the reality.
Write the formula and use it, it will work.
Because we've done that, because with what I just mentioned, with the walling, we've engaged the assembly for years. My predecessor did that. But this time, the other formula we used was, we took the challenge and we engaged a separate entity like the Teachers Credit Union. And when they came in, the assembly saw that they are kind of coming to take their shine, because we went onto the radio, mentioned intentionally the one who is funding, because the narrative out there was more of like the assembly is doing. So we corrected that. So the assembly saw that no, they will have to then come in to also at least be part of that success. So now they started coming in. But as I just said, you know, when you go, even though you may be aware of some funding that is supposed to be given to you, they will still tell you there's no funds. And you are not in their coffers. You can't tell whether that fund really is there or not. They can tell you it's just an announcement, but we don't have anything like that. Then aside that, in my district, it's more of like the literacy the literacy level is that it's low, it's a little low. So sometimes engaging them becomes a challenge. Some of the things you explain, it is difficult for them to really understand what you want to achieve with that engagement. So those that are helping us in some of the sub-districts, it is basically, they are looking at it like they have some money they want to do, so that you put their name on that particular project that you've done. Then people will see that, oh, this person did A, B, C. So it's more like when you give them that recognition, then they are ready to, but not merely they really understand what exactly, but we are on it trying to really explain where we want to get to, the needs that we want to meet, and where they can also come in to support us, so that together we can all achieve what we need to achieve.
Thank you very much. I think you just nailed it. More engagement. You know the essence of what you want, and hopefully with more education, we are getting to know that health is a business for all of us. Nananom, what are some of your challenges in terms, evaluating quality from your lenses of health services?
Yes, thank you. I was just thinking about this when Madam was speaking about the politicians. You see, what we are doing now is quality. No drugs are being prescribed here. You can't see no thermometer here. But the mere fact that you are educating the public presupposes that they are aware that there is quality somewhere. Because, but for this half-year review, nobody would venture out to provide quality. If there's something short, the citizenry will say it. So the nurses, the practitioners, the health practitioners know that there will be this half-year review, so they will do it well. It improves access. We are almost all the time at loggerheads with the politicians, because the very core of the existence of man that you want to become an MP over, or a district chief executive over, are the citizenry, are the people. But then when it comes to health, it is tag and pull. That again brings me to what is bothering me. The government has launched the 24-hour economy. When you go over all the television stations, particular reference to Joy, they do something like this on economy, something like this on economy. They go to people and they sponsor banks and on the economy. Why is it that you have not learned 24-hour primary health care services? Why? Why is it that there's no TV station here streaming this one live? Why is it that there's no noise in the community that something of this nature is happening? Why is it that I'm the only chief here? Why don't you take this one to the community? Why don't you go to Victoria Park? Why don't you go to Efutu? Why is it that the debtors have ceased all of a sudden, the health levels are seized. Why? So when we broadcast some of these things, when we bring it out, then the people become aware. Why is it that on TikTok now, everybody is saying that when you get this, you get that, you put together, it can cure one ailment. Where is the policy to stop them? Where is the policy to correct them? They are making access difficult. Those social media things, the government should have a policy to monitor these things for us, so that by the time it becomes serious and they get to the hospital, so many people are going to the hospital for the same ailment. Meanwhile, if the correct thing had been broadcast on the TikTok or WhatsApp or X or whatever, it will take care of these ailments before it becomes a national disaster. So, Nenanum can talk, and with our influence the citizenry to get access or to open their doors for visits, their health visits. But then, I believe that the policymakers should be up and doing also, so that quality and access are at the doorsteps of the people. Thank you. I don't know whether I've answered the question, but I'm very passionate about this.
You have more than answered the question. As the only politician here, I wouldn't ask you to attempt an answer. I would open the floor for just 3 questions or contributions to the panelists. And then we round it up and then go to the next section, please. If you need to ask a question to my expert panelists, just raise your hand. The mic will get to you. Yes. Judge, please. There's a hand here, behind there. Yeah. Okay.
Yeah, thank you. Yeah, we mentioned, or we discussed earlier about security with regard to the primary healthcare. And I think our primary focus was about the security of the healthcare personnel. But I think that if you go to the, sub-district, and especially to the chief center, the client coming in the night through the bush to access healthcare is also something we need to consider. Because if you don't think about this, what will happen is that we'll have a nurse station there, and she will just spend the night away without anybody coming there to access care. And let's all note, normally for healthcare at that time of the night, presuppose that the issue has got to a critical stage. Because normally, people will prefer to come in and access care, maybe in the daytime, if it's a normal condition. But for him to come in the night, there's a pressing need for healthcare. Have we also looked at professionalism, confidentiality at that level? I think it's something that should be of concern to us as we, journey toward this line. A very, very important thing that we need to look at as we improve quality. And then also the stakeholder. We as healthcare providers, already we are overburdened with a lot of responsibility. Monitoring, supervision, but it looks like now we are being told that spend all your time, go to the politician, and then go and source for resource. I think that when that thing is done, it takes us off our core mandate, which is to ensure that quality stay at the local level. And then we go around chasing for something that should be given, knowing that health is a concern for all. Because clearly, I think one of the panelists just mentioned it. If you go to a place and your BP just strike, it doesn't care where you are. Whichever facility is close by is where you access care. And what beside you, if quality is not good over there, you'll feel the pinch. So we all need to get involved. Not just us. NHI also have to get involved in all these things. Because as we said, at times you want to provide wellness services, but they will say there's no diagnosis. It's like it's a systemic thing to frustrate and prevent you from getting what is due you. But the care has to be given. Or maybe a specialist going to a chief center to support. Because I know as part of the NOP, we are supposed to provide both direct and indirect support to the sub-district. But when it goes there, it means that it's going to provide a service that is outside, the what is the name? It's like NHR will not really invest because it is above their level. So can health insurance look at how they are going to fine-tune their setup to support this primary health care? Thank you very much.
Thank you very much. I think that was more of a contribution. So the ambulance service will go and pick that patient in the night so that the snakes will not bite the person. Ambulance service, are you here? Oh, they are gone. So you go and pick the person in the night and don't ask the person to pay. And then at that point, any other contribution, please?
Yes, so moderator, I just want to make some submission. Our regional director, when she assumed office, within that week, she started her finalization visits. So there were a lot of stakeholders that she visited, of which the office of Ogabahini was not left out. So on the 21st of May this year, our regional director followed the protocol and she was ushered in to Ogabahini's palace. So this by way of correction that she will still continue to strengthen the collaboration between all stakeholders, and Nanano and all other stakeholders will not be left out. So she has already been to Ogabahini's palace, and that was on the 21st of May this year. So she will continue. She's not done because for health, we cannot do it alone. So when she came, quickly she asked us to identify key stakeholders that she can quickly visit, which she has done, and she continues to do that. So this is by way of information that the courtesy calls are still ongoing. And within that first week that she came to office, Ogabahini's palace was among the key stakeholders that she visited. Thank you very much. So to put your name, Bakosua na Kitamudibia was there, and then another Mutino, Akosua, like he said, the Baya, Pondia, one, and I go to Yabua, let me do. That's
Any other contribution, please?
Thank you very much. If you look at my face, you know that I'm a storyteller. And having been in the health system all this while, if I start my story, it will never finish. So, but I just want to leave two things, two or three. First one concerning what the young man, some of the things he said, that it goes beyond the surface. What actually goes on into quality and access goes beyond the surface. If you have a nurse who, didn't get something for the child this morning before she goes to work, all the fine theories can take place. You're never going to get it. So thank you very much for bringing that additional background to it. Okay. We will always come and kneel before you. I'm talking to the politician. We always come and do that. But look, frankly, it goes beyond that. What I want to say is that there has been a lot of knowledge going on here. All that is taking place. Look, I don't have that knowledge. You have everything. So I plead with you that as part of this review, all these discussions, you crystallize them and support the regional director to move forward. For example, 24-hour delivery of health care. Please, crystallize all. Then find out for each level what can be done locally, what you can do. Because you've already been doing it. CHIPS health centers, they do 24 hours. But it's not perfect. Crystallize and see what you can do locally. And then what she needs in addition to that. This sends me me to my final point about leadership. Look, let me make a frank statement. No country on earth has ever developed on this 4-year fractious democracy we have. Go through it all. There's no country on this planet that has ever developed on this 4-year fractious democracy. And the leaders will not talk for you and me. So, what they say, that leadership is cause, all else is effect. I have always thought the leadership is somebody else. No. The leadership is me. And you, all of us. We are the leaders. If we don't lead, please, listen to me. Thank you very much.
Thank you very much. I would take my concluding remarks from my experts, and then we would round it up. Nana, your concluding remarks, please.
So simple. Let us launch the 24-hour primary healthcare services with fanfare, pageantry, and all that will remain in our vision. Where are the local beds attendants to support the midwives? Where are they? Where is the mobile chief vans? Some government named it nicely. I've forgotten the name. Unyado. Where is it? It is primary healthcare. Where is the education to the church camps, to the witch camps, to the shrines? How about localizing the chief's compound mobile? That is the Unyado. I believe that it will provide quality, first-hand care before the tertiary institutions, the tertiary hospitals are flooded. That is why this one is true, but we won't say it. That is why people are dying at the referral hospitals, because they will leave their primary healthcare within their community, thinking that they don't have the capability, the quality, and move up there. By the time they get access to the doctors, their health situation has deteriorated. So the bottom-up approach, somebody has said it, send some of the professionals, those who are retired, to the chief's conference to help those there, so that the access that they get at first hand will be top-notch before they are referred. Thank you.
Yeah, I want to come in as primary health care. I don't want to come in, but as it's everyone's business. The health workers are doing their part. The politicians. What about the individuals? What are we doing in our own small way? If you see something, you see something. As Nana was saying, you not, like, you have some ailments, you keep yourself in the house, or you go to the shrine, go to other places before you access the hospital. But there's a saying that if you don't eat your food as a medicine, you eat medicine as your food. So we all have a contribution, we all have a stake to this primary health care. What are you informing your sister? What are you informing your brother? We shouldn't always point out to the politicians that are making the policies. We mostly implement them. What is our level of implementation? So let's all try, and in our own small way, also help to make sure that primary health care is really improved. We have the quality. Because our advisors, collaboration and all this can really take the primary health care to the top notch. Thank you.
Okay, thank you.
In my concluding remarks, I'll say access to primary health care. I will look at it in my concluding remarks 3 different ways. We need the staff, we need the equipment to work with. They also need the infrastructure. When you come to Aberdeenshire West, almost every community have a chief zone, but the staffing is not there. So what the challenge there is also is, you post a nurse to a community, the rent is such that the person cannot pay for it because it's a Galamsey area. But one single room there is ranging between 500 cedis to 1,000 cedis per month. So ask yourself, how can this poor nurse make up for this? So only this year, I think we've even written to the regional health directorate that some of the staff that we posted, they don't turn up because when they came, we're trying even to get the room itself. It is uncompleted building and you have to finish it up before you can stay in. So that's one of the challenges, that the access we are preaching, but on the ground it is difficult for it to be achieved. But we are still engaging though. And we are engaging persons that if they are able to build and at least rent it at a cheaper cost for our staff, and we are engaging the community, those that have some funds that they can do this, we are engaging them, including the rural banks that are there. Then the other thing too is, I think this one, let me digress a bit because it's something that happened in my district. The ambulance service. Just last week, one of our staff went to BBN hospital and he had a surgery. And for 3 days, we're looking for ambulance. It was difficult getting. And for now, we are just praying that nothing happened. The person had to go on her private vehicle. Somebody who came from theater. And the claim was that the person was in coma and need to be transported to Konfanoche. Imagine a route from that enclave to Konfanoche. You can imagine what is going to happen. So we are pleading that when we call, is there a way that we can contact directly those that are within our enclave, but not be sent to a central point before the call is relayed to the person that is very close to us? So that some of these things will not be losing life, because you are also part of it in the access story. Because if we need to transfer or refer a person and we are not getting that services, it means you are a barrier to the access. So thank you very much.
Thank you very much. I will not attempt at all to dilute what you've said. Mine is gratitude. I am grateful for helping do justice to this topic. I think the conversation should not end. I'm sure at another forum we will discuss this better. I'm sure Regional Director has heard our plea for a launch of a 24-hour healthcare. I'm sure the right ears will hear it, and then they will get the necessary responses. Madam Chair, my work is done. Thank you very much.
So as we conclude the second panel discussion, I would like to say a very big thank you to the panelists and for making this session so meaningful and engaging. The theme, improving quality of and access to primary health care services, is everybody's responsibility, reminds us that the task of strengthening primary health care cannot rest on the shoulders of one group alone. It demands collaboration across all sectors, at all levels. As Dr. Gatti said, he talked about collaboration. I think you are doing well there. He said, through collaboration, with the community and Nanano, they have helped with some infrastructure, including a mini theater. I hope the district office will stop seeing you as a competitor, but rather a collaborator. He also talked about they will need staff and equipment. Director, I think everybody is talking about human resource, so make it one of your priorities, and we believe in you. As Nana also talked about all-inclusive, he talked about home-based care. He talked about Onyado van. Nana was so passionate about asked so many questions that we have to ponder and answer them as we reflect on the theme. And there should also be a policy to regulate social media. It is really important. Nana, thank you. Madame Linda also talked about collaboration to bring the quality of services. And she has also given us an insight of how we can be close to the politicians to get what we want. Madam, thank you. You are not a politician, but you are more than a politician. Our moderator, thank you so much. You summarize everything and you make my work so easy. So we have had insightful reflections and practical strategies today, ranging from policy reforms and innovative services, delivery models, to the vital role of community participation and health workforce development. Each contribution has underscored that real progress, and it's only possible when everyone plays their part. On this note, thank you so much for the insightful discussion. God bless you. So our next presentation is about simulation-based training and quality improvement approach to capacity building in healthcare. We would like to invite Dr. Nkechi Dike from UCC School of Medical Science. Let's welcome Dr.
Good afternoon, everyone. I think while we wait, there's a short video, but I can introduce myself. I'm Dr. Nkechi. I'm a senior lecturer and an emergency physician at the University of Cape Coast School of Medical Sciences. And the topic I've been given today is looking at simulation-based training with its own contributions to quality improvement. What we have there was just to wake everyone up. It's difficult to have a conversation following that panel and just all the food we've eaten. So we wanted to just watch a short video of our most recent acquisition of one of our simulators. But in the meantime, I'll just start while they figure that out, just talking about what simulation, why this matters. As I listened to the two panel discussions, I kept on hearing things about refresher courses. I was hearing things about training, about outreaches, and just general access. So when you think about global health equity, everyone talks about the fact that health outcomes are dependent on access, on knowledge, and on capacity building. So where I come in, or where UCC comes in, or as an institution, we come in is to bring in that part of, and partner with the grassroots, partner with industry, with healthcare institutions and healthcare practitioners to improve skill, capacity building. It's multi-pronged. Just listening to the conversations today, it's a multi-pronged approach to this universal healthcare and primary healthcare 24-hour thing. But if we can contribute our part, and I'm so happy my dean was here this morning as a chair, and so he tasked with this to say, how can we partner with you at the level, at the primary healthcare level, to say, let's help you improve skill development. So one of the stories that led to me pursuing simulation was, and it was always a personal story. It's always, I'm an emergency physician somewhere in Ghana, and 2 countries down the line was my family going to my dad's 70th birthday. I'm a storyteller just like him, right? And somehow 2 countries down the line, being a great physician in another place, my family has an accident. And mother and 3 children dies in an accident. That's my uncle. As a physician, I went to see what should cause, what is the cause of death? It's an accident. But one person of the statistics, one of the people who died filled the statistics, she should die on spot. But the other 3 children were things that should not kill a patient immediately if we knew what to do. So I spoke to the person who received the body first at the nearby hospital, and the person hadn't ever passed a chest tube before. And when she tried, she knows what to do, but when she tried to see the steps to it, she ran out of data. She ran out of data to Google YouTube. I just wanted to think about if the life of somebody in your family is at the mercy of data, gigabytes and megabytes. That's a difficult thing. 2 weeks after that, I was shipped off to Mayo Clinic to work in the United States to do my fellowship in simulation. All I kept on thinking was, if I stayed here, I'll be one of many there. If I come back, I'll be one of a kind. And that's exactly why we do what we do, to say, if it doesn't matter how much we do, we don't know where an emergency will happen. A few weeks ago, one of my dearest friends, and I'm sure he made news across the media, died. He's a physician, he's an emergency physician. What he spent his life doing, he couldn't be saved of. And so, dear friend, we were only 6 in our cohort of emergency medicine. We're left at 5. It hits me every day, and it reminds me of why I do what I do with teaching simulation transferable skills and how this can help, because we don't know if quality means equity of care. It's not just social determinants of health. It's also, it's remediable. We can teach skills. It's avoidable. We don't have to die from things that we can repeatedly do. And that's where simulation comes in. Thank you so much. I was just by means of just speaking. I hope I've already woken some people up already. And so let's just watch something. This is just one of our newest acquisitions, and then I'll go into my talk. We're having some challenges, but that's okay. Thank you so much. Thank you so much. Can you help me just put up my slides? So this is one of our newest acquisitions in our simulators. And I know when we think about simulators, I hear people say we use dummies. This is not dummy. This is a huge computer. And I'm sure for those who come to, if you come to our trainings or our CPDs that we're going to put together this year, you will get to see this. We're using high fidelity mannequins, apart from the task trainers, and I'll explain what those are. We use high fidelity mannequins to train. I can kill this mannequin and resurrect it. I can't do that for a patient. I can do anything on this particular, I can give it any kind of disease, any kind of heart block, a stroke, an MI, whatever it is, and it can still live. We have the female equivalent where I've even done in some other country a perimortem cesarean section on, and it will self-seal back. We can bleed, my simulator can cry, can bleed, can sweat, can be cannulated, can be catheterized in real time. And so, I think we should clap for UCC. At least we invested something. Thank you so much. All right, so I've done my introduction. Just help me skip it to the next. Okay, all right, So just quickly, what is simulation? It's a training that is interactive, with hands-on learning in a safe environment. This is not a high-pressured environment. One of the questions that I've always been asked, or I always ask myself, is why should we practice on sick patients. And sometimes, even because I do that with undergraduates and postgraduates, but then we forget the spectrum of those already practicing. And that's where I come in and say, what are we doing for continuous medical education, in-service training? And so we can, knowing that you're in high-pressure environments every day, taking care of patients, can we remove you from that setting and then create the same kind of environment where you can practice with low stakes and then create and then help patients? So you practice clinical skills without risk to patients. We're able to also use simulation to build teamwork. Sometimes we've done this I used to work for the Nigerian Air Force, and I used to work for the Air Force in the military in other countries, and we usually take this simulation as well to the field. So I see some EMS, some emergency response team here. We also do that on the field at the airport. So we can take this thing just to see how teams work, how we respond to crises, and how decision-making can be made in real time. There are situations where I have put in students or learners into a scenario. So it's not only skill in terms of learning to suture. Sometimes it's also your mindset in the setting where you've done something several times. It's like muscle memory. And that's what simulation does as well for teams, where I've thrown people into scenarios maybe with chest pain. It took them 15 minutes to make differential diagnosis. After running it several times, in less than 3 minutes, they know exactly what to run. And that's the beauty of simulation. All right, so this is real skills, safe practice, and measurable results. Measurable. We can actually tell how well it's doing. Now, so the question I want to ask, does practice make perfect? Just one person. You've been quiet for a while, so I just want one person. Have you ever heard that? Do I see? Okay, I hear it does. Any contrary thoughts? Does practice make perfect? Okay, I hear more choruses of yes. So my question will be, so if I practice the wrong thing, it makes it perfect? Absolutely not. So permit me to push back and say, maybe practice makes permanent. So if you learn the wrong things, or you have not updated skills and knowledge over time, and you keep on practicing it over, some District B, I can't come for CPDs in town. And then the same thing you learned 20 years ago, 15 years ago, which is changed with AI and everything else, you're going to be perfect. But it's not really perfect. It's permanent. So let's change something today. In simulation, we say practice makes permanent, but correct practice makes perfect. Well done. All right, let's move on to the next thing. And so just to show you some of the ways that we use, these are mannequins. So I don't like when you call my real dolls, dummies. Please don't come and say, can we borrow your dummies? I won't give you. All right, so mannequins are full body computerized, like the one I showed you. It's what they can do these days will blow your mind. They replicate human beings to the degree that scares you, but then we can use that to our advantage. We can also do computer-based simulation. I kept on hearing telemedicine, tele-referrals. We can also simulate that. What does that look like if I'm in a district and I'm on a call? How do I refer? How do I speak? So communication can also be done by simulation. Task trainers is what we call just a part of the body where you are learning to do something. And then a standardized patients is real human beings that we have trained to simulate scenarios. For other things that we have will be like to debrief, and things are just terminologies we use. Now, how does simulation come in as your strategic lever in access and quality? It gives you equal access. So imagine if we taught every nurse and every PA and every doctor the same way to do a procedure in a particular region. Everybody knows the standard. So it's not like you're receiving a referral somewhere else where, we all know if it's an emergency, we should put a white ball cannula. We all know. But then now we have trained again and retrained that we know I shouldn't see a blue cannula. I'm just saying. All right. And then human performance, quality, and safety. And the whole goal of simulation-based education is not just care, access to care, but it's safe and competent care. Safe and competent care. All right, so several studies shows that WHO now recommends simulation across. This is what makes my work now more popular, where everyone says, in Kichiku, you come, Kigali, the Dean and I were in Kigali recently, and this was central to all the conversations that we're having at primary healthcare levels and at global levels, talking about simulation, because we've been found that it strengthens healthcare, delivery, health systems, workforce capacity. And just to mention, it's not only in terms of clinical practice, even the wellness of the people practicing on the field, we're able to collect and say, why weren't you able to do this? It could be tiredness, it could be a decision making, it could be a soft skill that isn't technical. So we use simulation to teach both soft skills and hard technical skills. So we can do that as well. And this is scalable. We can take this to the district level, we can come to the chiefs level, and I will talk about that towards, my slides are ending already. Just where you can partner with us as a director, thank you so much, and as a team, is that I want us, when we come to reviews like this and we have top mortalities in regions, maybe this is one thing I will propose, that we can look at your top problems in every area and partner with us as a skills unit, as a department in the medical school, to develop tailored simulation or trainings to those things. Sometimes we go into workshops and we talk a lot, but it's not targeting the exact needs. So we are going to the grassroots and we're saying, bottom up, tell us what the top mortality in this area is. Some things are amenable to simulations, some things are just workshops, some things are practice. So we can put that and say, the top 3 things killing people in this area, or killing patients, or top 3 things that nurses struggle with, or doctors struggle with, and then we can put that into a training and bring it to you. It's a mobile version of simulation. And we'll say you might not always be able to come to us, but we can, in partnership with the director and the directorate, say, fund this thing, and we will go to Mohammed. If Mohammed cannot come to the mountain will take itself to Mohammed and address those issues. Thank you so much, ma'am. And so we want to do this for Chiefs Compound. So why does it work? I think I've talked about this already. It's skill improvement, it's retention, it's working under pressure. We can simulate that several times. All right. And so this is just some of the ways. So I will be quiet while you look at this for a little bit, and just each of the slides talk about the kind of ways we can do simulation and these are real pictures of places that we've worked before. All right, so these are some of the things you can achieve with them. Just keep going. This is an actual setup I'd had before and worked to teach. Okay. All right, okay, and so these are some elements. I don't know if it's broad enough, but I would want you to just read. These are the areas that we can help you tackle. Adherence to protocols, decision-making skills, procedural skills, clinical knowledge, teamwork, communication, just to talk on a few of them. Well, let's move on. All right, so this is where my call to action to you all is. Thank you so much for giving me this very short time, but I want us to collaborate, just like I said. Help us help you create simulation-based workshop tailored to your context. It's not enough to call us, to say, oh, I need 15 points as a doctor, or 10 points as a PA, and just go for any kind of training that really doesn't translate to the kind of work and the outcome you want to have. So as district directors, or as heads, medical directors and medical superintendents, this is one thing you can do. And we promise, my dean was here, so you can hold him to it. Promise to partner with you, however we can, to tailor these things to the exact need that you have. And then finally, also we can collaborate by you sponsoring 3 to 5 team members or staff members to join our upcoming simulation program. And so we have, I think we have, these ones came from previous needs assessment that we have done, but going forward, I would plead that you tell us what it is and we will draft this for you. So we're having don't worry about the details at the bottom, the date, actually, when is our date again? Okay, so it's at the end of August or first week of September, we're going to work on that. But these two are going to be run together. The emergency and the complex wound management with suture techniques will be run together. So I would love if we can come, I think being in this room we will try to work out something that works really fine, but we're going to be using all of our equipment, all of our simulators. It's going to be an experience to remember. And then in September, the end of September, and the end of October, we'll be running something we call the Breathe. We use high fidelity simulation, the equipment you saw, to actually help you manage severe asthma. And these were particular needs. But going forward, we will start designing the CPDs with what you tell us you want. So thank you so very much. My team, Priscilla, is going to be here. My team member is here. If you want, and if you think, I want to sponsor my team members, I want people from my staff, nurses, doctors, PA, to be part of us, please let us know. We're here to take the first cohort. We are not opening this to the public yet because of this. We wanted to give access to you first before we make that public. Thank you so very much.
Thank you very much, Dr. Nkechi and your team. I assure you that you would have several cohorts from all our districts. So leave me to collate them for you. But definitely we are game. Thank you.
Thank you so much, Dr. Nkechi Dike. Today we've learned that simulation provides standardization of cases, promotes critical thinking, allows provision of patient care, provide immediate feedback, and helps students to assimilate knowledge and experience. Dr. Nkechi, you asked this question, does practice make a man perfect? I love it. I've never thought about this, but it's correct practice make a man perfect. Thank you, God bless you. Today we've learned something. Thank you so much. Madam, can we continue? And I hope we've all learned something. Correct practice. Correct practice. Correct It's allowed. If you have any questions, you can ask. One or two questions. Any question, any suggestions about simulation?
Okay. Dr. Chair, I think that there are no hands because the presentation was very, very easy to understand. Yes, and it was perfect. And I am sure all of them are thinking which cohort they would belong to because they all want the training and they want their colleagues back home also to get the training. In fact, CNMO was just giving me some eye and I said, don't worry, you are part of cohort 1. So all of us are going for the training and we thank Dr. Nkechi and team for that. Thank you. Over to you, Dr. Chair.
Thank you. So, Madam, we've been sitting down for a while and we want to get up and stretch for 30 seconds. Just 30 seconds. So that we can continue with the program. If it's okay with you, Madam. So please, let's get up.
So we are going to do facials of men. So where there is F, the women will sit. And where there is M, the men will sit. Please, do we understand? So I will sing, or we will all sing. I will make you fishes. F is for women, then the women will sit. Then the men will, so when it is men, then the men will also stand. I will make you fishers of men. No. Please, do you understand? So I will make you, I am a female. So I will make you fishers, then the men of men, then the men will sit. Please, do we understand? I will make you fishers of men, fishers of men, fishers. are starting. I will make you fishers of men, fishers of men, fishers of men. I will make you fishers of men if you follow me. So the follow me to the F is for the female, the me is for the men. So wherever there is F, the woman will sit. Wherever there is M, the men will sit. Please, can you go once again? I will make you fishers of men, fishers of men, fishers of men. I will make you fishers of men if you follow me.
Thank you so much, Anna. We will continue with our presentation on is CHIP still relevant in improving access to primary health care? The story of Gomwa East District. Let's welcome Mr. Felix Adipari from Gomwa East. Let's welcome him.
Hello. Yes. Good afternoon, everyone. Yeah. So my name is Felix Adipari, DDHS for Gomwa East. In the next 15 minutes or so, I want to convince you whether CHIPS is still relevant in improving access to primary health care. And I'll be using Gomwa East as our case study. So please indulge me for just 15 minutes and let me attempt to convince you otherwise. Okay, so this will be at the outline of my presentation. And we all agree that primary health care is the bedrock or foundation of our health care system. Now, we all know the definition of the Alma Mater Declaration of Primary Health Care. And we also do remember that Ghana also came out with a policy of primary health care in 1977, as far back as 1977. And they all speak the same language. Emphasis on scientific soundness to primary health care as a bedrock or foundation of the healthcare system. Now, if you all agree on this, then we understand why CHIPS was, the community-based health planning service was used as a vehicle or as a model to try to achieve the primary health care strategy in Ghana. Now, we all know the history of CHIPS. When it first started in Avrongo as an experiment, it was formerly called the Community Health Family Planning Project between 1994 to 1999. We all know how it was scaled up and it was replicated in Okwanta, in the Volta region, and based on sound scientific findings, it was later on adopted as far back as 1999 in Kumasi, and where the national strategy for CHIPS policy was drawn. We all understand that CHIPS is to be able to send healthcare services to the doorstep of the people. So I wouldn't want to bore you too much with the definition, but it's right here. Now, if we understand this, then the big question is it still relevant in this day? The model, the concept, the reason why CHIPS was developed as a vehicle to be able to achieve primary health care, is it still relevant? Well, I'll convince you in the very next few minutes. Now, this is an overview of Gomwa East District. We are zooming on to the case study. I want you to take particular notice about the total population. Very, very important for me. 350,280. We have the biggest population in the region. We contribute about 9.8% of the overall regional population. Trust me, my dear colleagues, if I'm a manager in Gomwa East, you hardly have sound sleep. Trust me. The population grows steadily at a growth rate of 3.1. And trust me, this was since 2021. Things have changed, actually. On paper, this is what it looks. but the population is growing faster than this. It means that on daily basis, there's a lot of burden on my health infrastructure, a lot of workload on my staff. And if you are a manager, then you have to think on daily basis, what can you do to be able to improve access, both geographical and financial. Now, if you don't come out with very sound strategies to be able to meet this demand of an ever-increasing population, then obviously there will be trouble for you. Now, aside this doesn't end here. I have nearly half of our population still in the rural areas. However, this population is still growing because the urban areas are growing faster and faster, and so it is what? Shrinking by the day. But these people, the 47%, still need quality of healthcare services. Aside this, I have population of chiefs that's over 200,000. This is a big demand for us. Aside this, I have a population that sees an influx or in-migration of people on a daily basis. A population that used to have the largest slum in Ghana, and a population that have diverse ethnic groups within. And a population too that seems to have the highest number of vulnerable population, the women, adolescents, and children. So that makes our case very, very challenging. Now, we have to come out with a strategy, which means that we have to use chiefs as a vehicle to be able to meet this population. This is just a summary of our infrastructure in Guma East. How has it helped us? Based on the scale-up of our chiefs, we've seen an improvement in the geographical access equity as far as primary healthcare is concerned. We have seen an impact in the reduction of our under 5-child mortality, immunization, and maternal and child services. And ladies and gentlemen, do not worry. I will show you evidence of this. This is not just a talk show. I'll show you the data, and I'll show you other visuals to prove my point further. Community participation is also central, as we have seen. And once again, I will show you evidence of this as I move along my slides. So, where is chiefs thriving in Guma East? Now, about 71% of all communities are being covered by chiefs. I have only 4 health centers, 2 child hospitals, 1 polyclinic. The majority of the health facilities that we have are chiefs. So if I pick out my chiefs out for my health system, then it means that about 71% of my population will have no access to healthcare services. Ladies and gentlemen, if I haven't convinced you at this point, let me move further. So, I'm going to show you very soon, in the next slide, how our immunization have improved because of the scale-up. I'll show you how our antenatal coverage have improved, and I'll show you how other indicators such as the effective management of minor ailments have also improved in my next slides. And in my last slides, I will show you how community trust and acceptance has been achieved through the chiefs model in Guma East. So here we go. Take a look at this. From 2021, when we started scaling up, we started with just about 11, 12 chiefs compounds. Now with the ones with compounds are numbering 14. Now when we scaled up and we pushed midwives into these chiefs compounds, this is what we are seeing. Skilled deliveries, over 200%. It simply means that in 2021, most of the chiefs compounds did not have midwives. But as the years went on, and as I started expanding and posting midwives there, you've seen what is happening here. Immunization of our primary healthcare system. You've seen the data. You can just have a look. I don't want to read any further. Let me show you a graphical presentation. This is progress from 2021, when we started, till 2024, when we scaled up fully. Now we are about 84% in terms of our coverage, actually, in terms of change functionality in Guma East. Now when we scaled up, you can see the data. You can see what the graph is, the visuals is telling us. This is a proof that change is still relevant if you want to achieve primary health care or our universal health coverage. But this goes without challenges. So there are few challenges that threaten to erode the relevance of chips. And one of them is urbanization. I've told you already, when I started, that about 52% of my district is urban. From Nyanyano to Bujumbura to Feta Akraba, those of you who seem to know my district very well. Now there's a spillover of population from Kaswa area into my district. Now, as the urbanization is coming in, it's beginning to threaten the existence of chips. Logistics is still a challenge. Every now and then, either we are having broken down equipment or there's actually no equipment. Some essential equipment are the chips compounds. Human resource also seems to be a challenge, where we don't have an efficient number or attrition rate. Most of them are moving out for greener pastures, so we are losing them. So this seems to be another challenge. And then accommodation for most of the nurses is also a challenge as far as chips is concerned. Weak linkages, referral systems. So our poor road network is a challenge for them, and also vehicles, transport system, the ambulance system. Inadequate community participation in some of the areas is also a challenge that seems to be trying to erode the relevance of chips. So as a DAD, we came out with our top 3 challenges that we're working on. So you can see a graphical presentation of what really worries us most and where, if we need to take action, we should target. So the question again is chips still relevant after I have gone through this presentation with you? I say a big yes, and I hope you agree with me. Yes, it still remains a critical component of reaching the underserved rural communities. Yes, it still brings services closer to the populations as its original model was created. Especially maternal and child health services, immunization and basic care. You have seen the data. It speaks for the today's. However, limitations are also curtailing what its potential. Without upgrades, chips still remain underutilized and underserved, which is true. And of late, if you have noticed, we seem to be viewing them as if they are clinics or hospitals or smaller clinics, versions of health centers, which you and I would agree that it is not. Chips goes beyond that. What are some of the opportunities and innovations that we have created as far as chips is concerned? In Guma East, I think we if I'm not wrong, we are one of the few districts or only district in Central Region that is implementing what we call the digital macro planning, where we use QGIS to actually profile of our chips compounds and health centers. And then we are able to map our outreach points, map certain very vital, landmarks into our maps, and we're able to identify new settlements, new populations, nomadic populations. We're able to target them, and we're able to reach out to them. This is essential because of our in-migration, our ever-increasing population. So we are one of the few districts that do that. With the help of PAF Ghana, this is what we do. We also have the e-tracker for EPI, another innovation or another pilot project that was supported by PAF Ghana as well. So we are doing this, and we are using chips to do this. We also, about 92% of my chips compounds have access to drones. There is zipline drone technology. So for just 10 to 15 minutes, any chips compounds in my district, with the exception of one, so the 92% is minus one particular compound, can virtually order for any essential drug or commodity, and it will be brought to them within the next 15 minutes. So it accelerates our logistics supply. Mostly we don't sometimes have to wait for last mile distribution. We can order for any essential logistic or drug right now, and within the next 15 minutes we have it. Something that I'm sure a lot of people don't have the opportunity to. We also have very strong public private partnerships. We have a very strong relationship with our child hospitals. We send our midwives to our our child hospital for training on Igbo, the chips. So St. Louis Hospital, if they are here, kudos to them. They've been doing this for me for the past 3 years. And this helps in building their capacity and augments what the region is already doing in terms of the safe motherhood trainings that have been implemented by the region every year. So that is some of the things that we do. And the private facilities are also supported, and they form some of the referral points for most of my chips compounds. We have a very strong partnership in that respect. And I will show you some of the pictures of how private-public partnership is working in Guma East. So what are my recommendations? Strengthen infrastructure. I've mentioned this as one of my challenges. Staff accommodation is still a challenge for most of my chiefs compounds, and I'm sure most of you here, managers here, will agree with that. Water, electricity is some of the challenges we face. And equipment, basic equipment. Every now and then, they run out. Every now and then, some of them are broken down. It's still a challenge, and I'm sure most of you can relate in this. Motorbikes for referrals. We don't have enough of them. And so, Regional Director, I'm sure you are listening to me. If you agree that this is still relevant, then together we have to work towards achieving this. Scale up community participation. Indeed, because for some time, if you agree with me, we don't make too much noise with the chief's tent. In fact, the sort of community engagement and mobilization is better dying. So when you go to some places, the CSCs and then the volunteers, spirit is dying a little bit, and I'm sure most of you agree with me in this one. We need to reinvigorate this, bring it back to where it's supposed to be or how it used to be 20 years back. And also improve the NHIS integration. I'm sure you will also agree with me if we need to achieve universal health coverage. NHIS is a key component of that. So we need to look at this as managers. And also monitor our metrics too, as far as this is concerned. The network of practice is one of the tools that we can use to actually get our chiefs compounds functional. If you look at the model, if you look at this concept, I wouldn't say too much on that. Community scorecard is one of the things that we can use to engage the community members. So accountability, transparency, as far as chiefs is concerned. In conclusion, ladies and gentlemen, chiefs still remains highly relevant and even essential for improving access to primary healthcare in Guma East. And of course, if you agree with me, Central Region. Critical gaps exist but are flexible with targeted investment and community engagement. With upgrades and better integration, I believe that chiefs can fulfill this promise in advancing universal health coverage in Guma East and as well as Central Region. I will leave you with this quote, that chiefs is not an option. Whether any district or health manager likes it or not, we need to adopt it. If you agree that it's still relevant, then it's not an option. A bit of gallery. We don't wait for permanent structures to be built. This is a community called Akoti. When we first started, this wasn't actually one of their health priority, their priority needs. But upon engagement and using our experience in community entry and mobilization, they gave us this structure, this 8-foot container. It was actually meant for a police station. We picked it up, turned it into a chief's compound, kept in the necessary relevant staff there, started working. Within a few months, they saw how important this structure was to them. Now, if you look at the other side, you see a very big, gigantic building over there. That is a health center they are putting up. Yes. Regional Estate Officer is here. He's wise or so to actually give his technical expertise on how it should be done. It's there. Anytime you go into Accra, when you get a tea, just look on your right. It's there, just by the roadside. You can't miss it. This is also Paramount Chief of Fete, Guma Fete. I have two Fetes. We have the Fete Accra and the Fete Me. So the Fete that's around Ojobi. This is a chief that has also seen the importance of chiefs. He's putting up nurses accommodation due to our cry for accommodation for nurses. He's also putting up a very big maternity block for them. And he has also renovated the old chief's compound for them. So you can see also that in your picture, in the pictures. This is Fete Kakraba. I told you I have two Fetes. The Fete big one and the Fete Kakraba small Fete. This community also initially did not see the need for chiefs. Where you see this place cited, the smaller one, the very not too nice one, was actually very close to a Deba ground. And so the plot of land that they had, they said they wanted a market, a Deba ground for funerals, not chiefs. We did engagement. We showed them how important chiefs was. We lobbied. Later, they went to the assembly, made the engagement, and then through CODA, they have a brand new chiefs compound built for them. That is Fete Kakraba for you. You can also see this on your way to Accra, anytime you are moving to Accra. The renovation. So this one too, Chief of Akraman also took it upon himself to renovate this chief's compound for them. Also seeing how important it is to his community. We also do not wait for government or community to build our structures, like I said before. Even market, when you give us a shed, we will come and then start implementing chips there for you. This place is Dominancy Market. I'm sure you are very aware of this place. Anytime you go there to buy onions, please, you can ask for Auntie Ness around in case you have some small headache. I'm sure she'll give you some paracetamol on your way back. This is Dominancy Market. There's a mobile chips compound over there. We are only using a shed, but we are implementing chips. I've bemoaned the lack of community engagement and all that. But that does not mean that it's all communities. We still have very active participation as far as chips is concerned. And these pictures prove so. These are some pictures with community scorecard that we're doing, and these are also some pictures that we're doing engagement with the chiefs as far as chiefs is concerned. So at this point in time, I'm sure that I've managed to convince you beyond reasonable doubt that chips is still relevant in this day. Thank you very much.
Thank you so much, Mr. Felix Adipayi. So, let me ask this. Is chips still relevant? Let me end with this thought. In the heart of every remote village, in the hope of every mother, in the cry of a newborn needing care, chip is not just relevant, it is essential. The question is no longer if chips is relevant. The real question is, how far are we willing to go to make it thrive again? Thank you, Mr. Felix. So let's imagine a Ghana without chips. Imagine mothers walking miles again, unattended, preventable deaths becoming headlines. That is not just history, it will be our future. If we forget, chip is the thread holding our primary health care fabric together. Cut it and the system unravels. Strengthen it and we save lives. Thank you so much again, Mr. Felix, and I hope, Madam, chips is going to be one of your priorities. Thank you. Yes. Please come for the chair. Please wake your neighbor if he or she is sleeping.
Please, good afternoon to you all, colleagues and senior colleagues. I'm by name Stephen S. Tieto. I'm here to make a presentation on building partnerships for service delivery in the primary healthcare using networks of practice. And let's look at the theme for this review, improving access to and quality of primary healthcare, everyone's business. When you look at the theme and you listen to all the discussions and the presentations that we have had earlier, I think it is becoming clearer to us all that partnership is the way to go if we want to achieve our universal health coverage. This makes my presentation simpler. We have all seen from the last presentation that it is through partnership that he achieved a lot. Quality issues came in. We saw that without partnership, we can't get quality. So I'll just launch on that. And this is my presentation outline. This is the experience of Ejumanku Enyang SCM district. We have a total population of 133,779 with 143 communities, 33 health facilities. Our sub-districts are 5 in number. The people are predominantly farmers. We are going to look at the concept and definitions. But the concept and definitions, I will not dwell much on that. We are seeing that primary healthcare is everyone's business. If you look at the definition of WHO and UNICEF in one of their technical series on PAC, they define PAC as a whole of society approach to health. A whole of society, not a section of society. A whole of society, how we look at the whole of society if we don't build partnership?